going to deal this uh, CVS examination practical aspects in some 2 to 3 parts. We'll try to accommodate all the information that is required for mainly undergraduates and also the postgraduates. And the practicing clinicians has also been considered while preparing these classes. So I want to deal this CVS examination in 2 to 3 parts. First part, I will be discussing only the CVS examination per se, that is the inspection and palpation part, and the auscultation part. I think we need to be covered in 2 separate parts. We'll see how it goes. So today we'll discuss the first part of CVS examination, the practical aspects that are required for the undergraduates and also the postgraduates. And we know that traditionally we have been examining these important systems under the main headings of inspection, palpation, percussion when required, and the auscultation. And since the ancient times, the inspection and palpation of the anterior chest and the precordium is a very important part of the cardiovascular examination. Remember, the only a positive palpatory findings will be taken of very much importance compared to the auscultatory counterparts. Only, see, what I meant is we cannot have a positive auscultatory findings in a patient of CVS pathology without having an abnormality in the palpation. Like you cannot say that a patient inspection and palpation, you don't have any positive findings, but you have got some hormones on the auscultation. So that does not work. The palpation usually shows some of the positive findings, which will be confirmed in the auscultation. So, and these inspection and palpation findings that are going to be discussed have been correlated constantly with the non-invasive studies, the hemodynamic data, and the surgical and autopsy studies. That's how these have came into existence, all the science and all. And they are an important part of evaluation of all the cardiovascular disorders. So traditionally, we know that we are discussing the systems under these 4 headings. And first, coming to the inspection of the anterior chest and precordium includes the following aspect. First, we need to examine the chest for its shape, size, something like that, the cutaneous lesions, the breast abnormalities, the dilated veins, some scars, etc. And you need to examine the precordium for any precordial bulging, a very important sign. Cannot miss a precordial bulge. And you need to examine the cardiovascular system for the pulsations in different sites. One is the apical impulse. Then we know that pulsations in the right and left intercostal spaces, that is traditionally called as aortic and pulmonary areas. And you also need to look for some pulsation in the elsewhere also, like sternoclavicular area, suprasternal area, parasternal area, epigastrium, and some ectopic beats if they are there. So we cannot miss any obvious visible pulsations during examination. If you miss and the examiner finds them, then it can be a problem. So in doing this, the patient should lie comfortably in supine position with the thorax elevated preferably to 30 degrees, and always examine the thorax, that is the cardiovascular system, tangentially, first from the foot end of the bed and then from the patient's right side, directing a beam of light across the precordium. This is a very important thing. The patient's position during examination should be like this. So first, you want to know the shape of the chest. So majority of these will be revisions for you and will also be shared during the discussion of respiratory system examination also. So we know that normal chest in an adult, a normal adult is bilaterally symmetrical. Sometimes you may get a right-sided more hypertrophy than left-sided, but more and more of it is bilaterally symmetrical and elliptical in cross-section, in which the transverse diameter is slightly greater than the anterior-posterior diameter and has a subcostal angle of 90 degrees. Whereas in children, rather than elliptical, it will be something oval shape. And there are abnormalities of the chest shape and size that will be discussed accordingly. So the types of abnormalities of shape of the chest with respect to cardiorespiratory diseases should be known. We know that barrel-shaped chest in which the AP diameter of the chest is more than or equal to transverse diameter. It is called an emphysema secondary to lung hyperinflation. You have got a muscular thorax but a very thin lower limbs. It's a feature of coarctation of aorta. A shield chest that is a very broad chest with an increased interareolar distance is a feature of Turner or Noonan syndromes. And we have got very famous pectus carinatum, that is pigeon chest, in which the sternum is protruded outside. And we have got pectus carinatum, which is funnel chest. Both are feature of Marfan syndrome. So for the posterior diameter is more than transverse diameter. This is a very typical feature of emphysema or lung hyperinflation in COPD. So the cardiovascular importance of this shape is uh, any pathological abnormalities are like, for example, if there is a right ventricular enlargement, ventricular enlargement, you have got direct pulmonary artery, all these pulsations can be missed if the patient have a coexisting emphysema. And this is a pigeon chest, also called as pectus excavatum. This is pectus carinatum. This is what I was describing. The shield chest can also shield a very short neck in where interareolar distance is very large. So this is a feature of Turner's thick upper body versus a very thin lower body. This is a feature of coarctation of aorta. This, if you see, you can never miss it. So this person, even if he looks body which has got a very hugely built in upper part, whereas if you see his legs, they are pretty thin compared to the upper part of the body. What are the cardiovascular significance of some breast abnormalities if you want to know? If you see any male gynecomastia, you need to correlate this with the adverse effect of some drugs which are used for cardiovascular disease like the digoxin and the spironolactone, that is the mineralocorticoid receptor agonist. Very common side effect, and often it is a painful gynecomastia. The drug-induced gynecomastia is usually painful. A female hypomastia is a feature of mitral valve prolapse. This is also pretty common. So a lot of young females with hypomastia are coming with recurrent palpitation and some atypical chest pain. Many of the physicians usually look for the coronary related issues, but tend to miss mitral valve prolapse. Even the echo sometimes miss mitral valve prolapse, but you need to have a high level of suspicion to diagnose mitral valve prolapse. And as I said, the widely spaced nipples with an increased interareolar distance is a feature of Turner hormonal syndrome. And next, after the confirming the shape of the chest, you need to look for some scars and etc. that you are all aware of. But be careful to look for sternotomy scars, which gives a very important clue that previous cardiovascular surgery. Very important thing. Patient might have undergone the valve replacements, the coronary bypass surgery, etc. That should not be missed. After looking for the shape and the scars and etc., you need to look for the dilated veins and the dilated arteries. The dilated veins, we know, in the upper part of chest is usually a feature of SVC obstruction, and dilated arteries, especially over the axilla and the back, is a feature of coarctation of aorta. This is how you look for the dilated arteries, the tortuous arteries. Ask the patient to bend forward. Next, you need to specifically mention that is there any precordial bulge or not. So, what is the importance? The precordial prominence can be there without including the ribs or with including the ribs. So if the precordial bulge is there, but the ribs are not involved, then you can suspect the disease related to the pericardial effusion, etc. Long-standing pericardial effusion, especially that's seen in hypothyroidism, can be a feature of this precordial bulge in adults. Whereas, very important, when we mention precordial bulge in cardiovascular examination, it means that there is some cardiovascular disease which is there since a long-standing cardiovascular disease, especially in childhood, will produce precordial bulge because the ribs will be pliable during that age. And invariably, these patients will have AST with an increased pulmonary blood flow. So, any adolescent, if you are examining, have a precordial bulge, you need to suspect either AST or sometimes even VSD, which is having an underlying biventricular enlargement with an increased pulmonary blood flow, can have a precordial bulge. But all the other the examination cases, the valvular diseases like the mitral stenosis, the mitral regurgitation, or other valvular diseases are very unlikely to have significant precordial bulge at the adolescence. This is what you should remember. But if there is a precordial bulge, how will you look for a precordial bulge? You will ask the patient to lie down 30-degree elevated, and you should look the precordium tangentially from the right side, throwing the beam of light. So that's how you will look for a precordial bulge. And if it is there, don't miss it. And if the examiner asks what is the importance of precordial bulge, just say any precordial bulge suggests that there is a long-standing cardiovascular disease developed during a young age. This is how you should say. You can never tell that it is due to ASD, it is due to VST, it is due to mitral regurgitation. You cannot definitely say that the precordial bulge is due to some particular cardiovascular disease. It can be there in any disease which is there since long standing, but more commonly it is seen in ASD and VSD. Now coming to the very important aspect of the inspection, that is the apical impulse. So what is the apical impulse? It is the outermost and lowest point of maximum cardiac impulse that is seen during the inspection. So some people call it point of maximum impulse, that is PMI. The better terminology is the apical impulse, because when you mention that point of maximum impulse can be anywhere. For example, if a patient have a descending aortic aneurysm, he can have a right parasternal maximum impulse, but that's not the right way to say it is due to apical pathology. So the apical impulse is the right terminology to use while describing the apical impulse. So what is the difference between a clinical apical impulse, that is the apex, the true anatomical impulse, and the radiological apex? There is a slight difference. See, we know that the heart is an inverted cone-shaped material which is base situated in the outside, or that is upper part, which is base. So we usually have the clinical apical impulse. This is a true apical impulse. This is the radiological apex. So radiological apex is the most lateralmost part. This is because it includes the epipericardial fat and etc. That's why the shadow appears to be little lateral. Whereas the true anatomical apex is somewhere medial to the radiological apex, and a clinical apex beat is further medial to the true anatomical apex. So that's what we should know. The basic point that we want to confirm here is whatever the apical impulse that we are going to feel during the clinical examination is not a true anatomical apex of the heart. It is a clinical apical beat. It is somewhere situated in the interventricular septum and the left ventricle anterior wall, but it is not true clinical apex of the left ventricle. So why does it produce? It produces due to a counterclockwise rotation of the left ventricle during the early systole. So if this is the right ventricle, this is the left ventricle. I have shown right ventricle bigger than left ventricle because the left ventricle is situated more posteriorly, whereas right ventricle is situated more anteriorly. The counterclockwise rotation, when you see it from the below, the heart moves in a counterclockwise way during the early systole, which makes the left ventricle to come forward and touch the overlying thoracic wall. So this impulse is felt as an apical impulse during the examination. So the normal apical impulse, it comes out during the early systole, that is along with S1, and stays on as an outward movement as long as the ventricle ejects blood into the aorta. And the outward movement retracts from the palpating finger well before the second heart sound, covering usually two-thirds of the systole only. And the duration of the outward thrust is a reflection of the duration of LV ejection. If the LV ejection is taking more time, then the duration will also be more, wherein called as sustained apical impulse that we will be discussing later. So during inspection, you need to mention whether the apical impulse is present or not. That's all. You cannot usually define the character of the apical impulse during the inspection. Maybe some hyperdynamic impulse can be seen in which the apical impulse is seen in multiple intercostal spaces. So the normal apical impulse is usually situated at or medial to the midclavicular line in the fifth intercostal space. And it is roughly around 2 to 2.5 centimeter, but practically it is usually limited to single intercostal space. Apex peak normally cannot be seen or felt in more than two intercostal spaces. If it is so, then it usually suggests a pathology. And how much amplitude that you are going to feel is a subjective thing. You cannot objectively measure the amplitude of the exertion, but the duration is usually 50 to 75% of systole only. So how will you time it? You will be going to time it the simultaneous palpation of carotid artery. It comes out with S1, stops much before S2. So during inspection, just say whether apical impulse is seen or not. If it is seen, where it is seen, whether it is localized to single intercostal space or it is seen in more than two intercostal spaces. That's what you are going to comment during inspection. Then you need to look for any other pulsations elsewhere in the precordium. Mainly you are going to look for the second intercostal spaces on either side. The right side is called aortic area, the left side is called pulmonary area. I have given some reasons for the pulsations in the respective sites that you can go through. And if you see any pulsations in the sternoclavicular area, that means they're much higher than the aortic and pulmonary areas. The reasons are usually similar, something related to aortic aneurysms or etc. But very importantly, that you need to see is, are there any pulsations in the left parasternal area? If there are any pulsations, any significant pulsations in the left parasternal area, especially below the second intercostal space, that is third, fourth, or fifth intercostal spaces in the left sternal border, you're usually going to locate the pathology into the right ventricle. It can be a right ventricular pressure load conditions or right ventricular volume overload conditions. These usually manifest as the pulsations in the left parasternal area, in which we are going to confirm by palpating for the parasternal heave or impulse. Sometimes even the RV can be normal, yet we can see some pulsations in the left parasternal area. The main two reasons are a very large LA that is usually seen in mitral regurgitation, and sometimes a regional valve motion abnormality of the left ventricle can also be seen as a parasternal area impulse. And next, you are going to look for the epigastric pulsations. Epigastric pulsations can be due to cardiac pathologies, it can be due to aortic pulsations, or it can be sometimes the hepatic pulsations related to Uh, it's tricuspid regurgitation, tricuspid stenosis, etc. But the main reasons for epigastric pulsations are the cardiac and the aortic areas. In a thin individuals, even a normal aortic pulsation can also be seen in epigastric areas. While in palpation, we are going to confirm whether the epigastric pulsation, if it is seen, it was due to cardiac right ventricular hypertrophy or it is due to aortic pulsations. So, to summarize palpation, we need to see the patient has to be put to the supine position with 30-degree elevation. You need to look tangentially from foot end and also from the right side. You need to look for the shape of the chest. You need to look for any scars. You need to look for the precordial bulge. Try to see the apical impulse if it is present or absent. I mean, it is seen or not seen. If it is seen, where it is seen. And are there any other pulsations? So main areas that you are going to look is the aortic area and pulmonary area. Then suprasternal area, the sternoclavicular joint areas, the parasternal area, that is left side, and epigastric pulsations. So this is what you're going to comment during the inspection of the cardiovascular system. Whereas in palpation, you need to confirm the inspectory findings. For example, if it has the dilated vessels, especially the veins, you need to decide the direction of the flow. Those are all are mandatory. And next, you need to check for the palpation and tenderness, local rise of temperature, and all these things. Then you need to palpate for the cardiovascular pulsations that you have seen, or if it is not seen, you are specifically going to look for apical impulse, parasternal pulsations, and the aortic area, pulmonary area, the epigastric area, and all these things. Look for any palpable thrills, rubs are there, and you also need to examine for the tracheal tunnel. So this, in which you should also confirm the position of trachea before going to proceed further. Because if there is a shift in the apical beat, plus if there is also a shift in the trachea, then it is usually suggestive of a mediastinal shifting rather than a cardiac pathology. The tracheal position should be normal before before comparing or before writing down the apical impulse pathology. So there are some diseases in which there is precordial tenderness. The teeth syndrome, we know, is also called as costochondritis. Sometimes a pericarditis can have the tenderness. Very rarely myocarditis can have tenderness, but it is usually due to an overlying pericarditis. So there are two diseases which can produce precordial tenderness. One is the costochondritis. Apart from trauma and all these things, I'm saying very important cardiac pathology that can produce precordial tenderness, especially the direct sternal tenderness, is pericarditis. Coming to the palpation, the palpation of the precordium is performed from the right side of the supine patient with the upper trunk elevated to 30-degree and chest completely exposed. The palpation of the apex beat should also be done in a left lateral position after turning the patient to 45 to 90-degree, to which it causes the heart to move laterally and increases the palpability of the apex if it is not palpable during the supine position. And you should use the palm of the hand and ventral surface of the proximal metacarpals for the initial localization to palpate any cardiac motion, while the pads of the fingers are used for the precise localization and assessment of the ventricular activity. And all precordial activity should simultaneously be palpated with the carotid pulsations. This is very, very important. For example, if the examiner usually asks, demonstrate the apical impulse in your patient, so your answer should be, first, I want to expose the patient, his precordium, and I want to make him supine and his chest elevated to 30 degrees, wherein I am going to put my fingers along with my ventral surface of the hand, first to initially localize the site. Then for the precise localization, I'm going to use my fingertips while simultaneously palpating the carotid artery to time it. This is very, very important. So where all you are going to palpate, first you are going to palpate the cardiac apex, that is presumed cardiac apex. Then you need to come for parasternal area, go for lower left parasternal area, then aortic and pulmonary area, sternoclavicular area, epigastric pulsations, and ectopic beats if there is any. So that is how your system should be. So this is a traditional way of examining. The precise localization or any localized pulsations are usually better felt at the fingertips. Some thrills are usually best appreciated in the proximal metacarpal areas, and the proximal wrist or the wrist joint is used especially to palpate the parasternal heave. So how to palpate for the apical impulse? The initial position is place your flat of the hand just like shown in the picture on the patient's precordium in the normal probable apical impulse set, that is the left fifth intercostal space covering the anterolateral rib cage. Search for the beat. If no pulsation is felt, gently move your hand in various directions to locate it and determine the prominence. Confirm if the apex beat is the most prominent pulsation or not. Apex beat has to be the most prominent pulsations. You may be feeling various pulsations in the some areas, but you need to locate for the site for the prominent and maximum sensation, and then identify its location by palpating the sternal angle, count down the rib location and identify the intercostal space, etc. And you can measure the distance. The usual distance that is to be measured is the midclavicular line, wherein you are identifying the medial edge and the lateral edge. It is very difficult to exactly pinpoint the lateral edge, but never consider nipple as a landmark. The majority of the people usually consider nipple tends to lie at midclavicular line, but it is not so. Then you can also take the lateral border of sternum and mid-sternal line also for the measurement as a landmark. Some examiners prefer these measurements also. So what all points you are going to measure is first whether it is present or not. If it is present, where it is located, what is its size? That means whether it is a localized apex beat to a single intercostal space or it is diffuse. Amplitude, whether it is forceful or not, and this is a very subjective feeling. You will appreciate the forceful apical impulse only after seeing 100 to 200 normal apical impulses. And next, you are going to assess the duration. What is the type? That is, we have got specific characters that you are going to label it. Is there any associated thrill or not? So the normal apical impulse is situated in the fifth intercostal space, just medial to midclavicular line. And as I said, it is, excuse me, it is usually 2 to 2.5 centimeter width, never felt in more than one space. We don't have any objective measurements for the amplitude, and duration is usually systole. 50% of systole. So if this is S1 and this is S2, if this is an apicogram, so this comes just after S1 and stops or goes back much before S2. So this is how the normal apical impulse is there. So what causes the absence of apical impulse? So before going to this, what is an absent apical impulse? So when do you say that apical impulse is not felt? This itself is a question. So to say apical impulse is not felt, you need to examine first patient in supine, next in left lateral position, then after seeing the right side. Then only you can say that apical impulse is not palpable. Remember, in the normal individuals, in 50%, normal individuals, apical impulse is not felt. But to say apical impulse is not felt, you need to check in all these three positions. By just checking in a supine position without testing the site of apical impulse in left lateral position, if you say it is not present, then there is a problem. So, what are the physiological causes that can cause the absence of a apex beat? Is dextrocardia that you should not miss. Then, if it is a behind the rib, it can be get missed, and if there's a thick chest wall, it can be missed. What pathology causes an absent apical impulse? One is the obesity, some pericardial effusion, the pleural effusion, and emphysema. So these respiratory and pericardial pathologies can be the pathological reasons for absent apical impulse. So when somebody, you should know when to call an apical impulse not palpable or not felt, and you should also know what can be the cause for this. By the time you say apical impulse is not palpable, the next question the examiner is going to ask you is what are the causes? And the examiner asks causes, you should always say in a proper manner. So there are physiological causes and there are pathological causes. The location, as we know that we need to assess the tracheal position before commenting on the apical impulse. Because if there is a simultaneous displacement of trachea along with the apical impulse, it usually suggests the mediastinal shift as a result of the fibrosis, collapse, pneumothorax, or effusion, etc. If the trachea is central, but the apex is displaced, for example, as I said, the normal site is fifth intercostal space, medial to mid-clavicular line. But if it is displaced, it can be displaced outward or it can be displaced outward and downward. So in LV enlargement, in the diseases causing the left ventricular enlargement, the apical impulse is shifted both downward and outward. So down and out. We usually say down and out. And RV enlargement can cause the apical impulse shift to out only, but it will still be in the fifth intercostal space. So this is a very important finding. To say which chamber is enlarged, you need to locate the site of the apical maximum apical impulse. So in RV enlargement, it is in the same intercostal space, but it has shifted outward. Whereas in LV enlargement, it can be shifted both down and out. And size, we know that normal apical beat is located in a single intercostal space. When it is felt in more than one intercostal space or more than 3 centimeters. More than 3 centimeters means 1.5 fingertip. So if it is in more than one intercostal space, more than 1.5 fingertip, more than 3 centimeters in diameter, then it is going to be called as diffuse apical impulse. The diffuse apical impulse is usually seen in a volume overload conditions. It can be valvular lesions like the mitral regurgitation, aortic regurgitation. It can also be due to anemia, thyrotoxicosis, sometimes the Paget's disease of the bone, some AV malformations. Any volume overload conditions can cause a diffuse apical impulse. And what do you mean by diffuse? When it is felt in more than one intercostal space. Amplitude, as I said, we don't have any objective measurement. Usually comparison to the normal apical impulse. And it is called forceful and it usually lifts your palpating finger. If this can, although it is very difficult to compare, it still be a subjective feeling. But when it lifts your palpating finger, we can call it forceful. And what is the duration? The normal duration is very, very important. The normal duration is less than 50%, although some textbooks tells that it is 75% of systole, but it can never touch S2 or appear beyond S2. When it is more than two-thirds, it is called sustained apical impulse. You need to time with S1 and S2 by simultaneously auscultating or simultaneously palpating the carotid artery. So if it is touching S2 or coming beyond S2, then it is called sustained apical impulse. So the sustained apical impulse is usually a feature of pressure overload. So For the left ventricle, it is usually the aortic stenosis, the HOCM, that is hypertrophic cardiomyopathy. Then the systemic hypertension, long-standing systemic hypertension can also cause a sustained apical impulse, which tells you that the LV is hypertrophic. That is called as concentric hypertrophy. And based on these characteristics, we have got different types of apical impulse. One is tapping, one is hyperdynamic, another one is heaving. So these are standard terminologies. So what is tapping apical impulse? A tapping apical impulse is very difficult to describe, but it just taps the touching finger and occur along with S1. So this is in fact a palpable equivalent of first heart sound, usually seen in mitral stenosis. So it is a very characteristic feature of mitral stenosis in which apex beat is usually impalpable, but it is replaced by a short systolic tap, the palpable equivalent of loud S1. A shortened outward movement of the apex during early systole due to reduced ventricular filling during diastole gives an apex beat with sharp, short tapping nature in mitral stenosis. It is also called as hypodynamic apex, which tells you that your LV is underfilled due to a proximal stenosis, that is in the mitral valve. These two are very, very important. What do you mean by hyperdynamic? The hyperdynamic impulse is felt in more than one intercostal space. It is forceful. That means it lifts your palpating finger. When it is ill sustained, that means its duration is normal. It is not sustained apical impulse. It is seen in volume overload conditions like the aortic regurgitation, mitral regurgitation, left-right shunt like ESD, VSD, PDA. And there are some non-cardiovascular causes also, like as we see the anemia, that is especially the chronic anemia going into failure. Then you have got the thyrotoxicosis, you have got a very large AV malformations, etc. Then what do you mean by forceful and sustained? In which the apical impulse is forceful, lifts the palpating finger, and it is sustained. It is more than two-thirds of the systole. It is usually seen in a patient of pressure overload condition, as we see in aortic stenosis, the systemic hypertension, the hypertrophic obstructive cardiomyopathy, and some coronary artery disease related ventricular dysfunction, and also the LV aneurysm can cause the heaving apical impulse, that is forceful sustained apical impulse. In clinical examination, when you're writing the case sheet, prefer to use the terminologies like the apical impulse is diffuse, it is forceful, ill-sustained, or sustained, which gives a better picture rather than using hyperdynamic apex is felt, heaving apex is felt. It is better to be very clear when you're writing your case sheets. So, how will you describe an apex beat if, for example, you're seeing a case of mitral regurgitation? I'm going to say that apical beat is situated in the sixth intercostal space, lateral to midclavicular line, felt in more than one intercostal space. That is, it is diffuse, it is forceful, and it is ill-sustained. This is how you are going to describe an apical impulse completely. So, what is the clinical importance of hyperdynamic impulse? The hyperdynamic apical impulse is diffuse, as we say, and very obviously, it makes your precordium very active with a brisk motions visible to the naked eye. For example, if there is a mitral regurgitation or aortic regurgitation, your precordium is very active, it's pulsating rapidly. Whereas in a stenotic lesion like the aortic stenosis, the mitral stenosis, the precordium is not having a very brisk motions. And this hyperdynamic impulse, what does that implies is left ventricle is dilated significantly. That means there is something called as eccentric hypertrophy. That's what you use the terminology. And the wall is not much hypertrophy. If there is a simultaneous hypertrophy, it will be sustained. It will be diffuse and sustained. Whereas hyperdynamic apical impulse is forceful, whereas it is ill sustained. So ill sustained because the wall is not hypertrophied. So there is an eccentric LV enlargement. It also tells, or it also gives you the importance that the LV function is well preserved. As the term hyperdynamic infers a very active left ventricle, and it is for obvious the dysfunctional left ventricle cannot be hyperactive. That means the patient has not gone into a severe failure. So the hyperdynamic LV apex in a patient with aortic regurgitation and mitral regurgitation, it indicates that they will do well after surgery for the simple reason that their LV function is preserved. So these are the importance of identifying these signs. And in the same logic, patient with hyperdynamic apex often complains of a palpitation as a very prominent symptom as their apex hits the chest wall very commonly, and it's a very good sign in reference to the LV function. So it does not mean that palpitation is a good sign for LV function, but what we mean here is whenever you see an hyperdynamic impulse and your diagnosis is mitral regurgitation and aortic regurgitation, that means it's a very best time to get their valve repaired. Once they go into a chronic failure, even after repairing a valve, the mortality cannot improve. And another important thing that you're going to comment is the apical impulse, in which chamber is enlarged. We know that the very outset, the right ventricular enlargement shifts the apex out, that is in the same intercostal space, whereas a left ventricular enlargement shifts the apex down and out. So this is one important reason. And there are other subjective methods also, which tells us that if you, while palpating the apical impulse, check for the sensation. In the left lateral decubitus position, the LV impulse feels as if a ping pong ball were protruding between the ribs in systole, whereas RV impulse is usually more diffuse. And look for medial or lateral retraction. An LV impulse, that is a left ventricular impulse, will manifest a medial retraction because the counterclockwise rotation of the heart. Whereas if the RV is enlarged, it is more of a lateral retraction. So this is another way to identify which chamber has enlarged. So normally, except the region of the apex, all the other walls of LV move inward to generate a pressure inside the chamber, except the juxtaapical area, which produces an apical impulse. When any of these regions is ischemic or infarcted or thinned out, it can produce a paradoxical motion. Paradoxical systolic upward lift may occur in the region which is infarcted between the apex and left parasternal area. So this is called as a palpable diskinetic segment. This is for the postgraduates. Palpable diskinetic segment or a precordium during angina has a more diagnostic value than an exercise test or a coronary angiogram, as the coronary angiogram can only reveal an anatomical obstruction but fails to predict whether the patient's chest pain is related to the lesion at hand or not. What it means is if the patient presented you with a chest pain, you do the coronary angiogram, and if the blockage is 80%, and you don't know whether this 80% obstruction has produced the symptoms or not. If they have a palpable dyskinetic segment along with an 80% obstruction, along with the chest pain, this becomes a very sensitive sign. Yes, the dyskinetic segment is due to the obstruction and you need to repair it. Next, coming to the palpation of the parasternal area. There are various methods to palpate the parasternal area, that is parasternal heave or impulse. First, you can use the heel of the hand with a wrist cocked upwards like this, as the heel of the hand is very sensitive. You need to keep this hand in the lower half of the sternum during the hand held in inspiration. That is also hand held in expiration. That is also called as inspiration apnea. Some textbooks mentions as inspiration apnea. Some people mentions that it is at the end of the expiration. Both are same. The movements of the examining hand and finger should be carefully observed because the left ventricular impulse is better seen than the felt. Alternatively, you can keep three fingers in three intercostal spaces and check for the pulsations. This is another method where you can palpate with the ulnar border of the hand, and pulmonary artery pressure can be judged clinically by applying the pressure. So if you feel any impulse or any heave in the parasternal area, you need to grade it as per grade 1, grade 2, grade 3. What is grade 1? Grade 1 is where in which the lift is very obscure, and while keeping the light objects like a pencil or a pen or a scale along the left parasternal make it very obvious. Otherwise, it is very obscure and it disappears with the application of pressure, and it is insustained. It can be seen in normal people, in thin chest wall, and pectus excavatum patients. Whereas grade 2 is pathological, always pathological, in which there is an obvious lift, but by applying the pressure, it is going to obliterate. This is called a grade 2 parasternal heave. It is seen in mild to moderate pulmonary hypertension, in volume overload conditions, and the sometimes a severe MR or a moderate to severe MR in which the LA is enlarged. It can produce grade 2 parasternal heave. Whereas an LA enlargement cannot produce a grade 3 heave, in which the grade 3 heave is very well sustained. You need to apply a very huge pressure, or a pressure does not diminish the parasternal lift. It is a feature of a severe pulmonary stenosis and a severe pulmonary artery hypertension. Then you need to palpate for other areas like tricuspid areas, but it is these things are very difficult to appreciate. But we can see that RVS3 and RVS4, especially in the pulmonary artery hypertension, if you have seen this, you cannot miss. So even I have seen few of the patients presenting as a carpal nail, we can have RV score in them. So, and sometimes an organic tricuspid stenosis, very rare opening snap can be felt in the tricuspid areas. And in pulmonary area, aortic area palpation is very, very important. They should be palpated in a sitting position with a leaning forward position. This is also very, very important. When the examiner asks you to demonstrate the palpable P2 or the pulsation in the pulmonary area, the patient should be asked to sit down and lean forward. In pulmonary area, pulmonary hypertension can produce a palpable P2 or pulmonary area lift. In aortic areas, the reasons can be the aortic stenosis, it can be a long-standing hypertension, it can be a dilated aortic root, or some congenital heart diseases like the transposition of great arteries or the nephrology of Fallot. Then, if there are any precordial thrills, you should examine for them. In apical areas, if the systolic thrill is felt, it is usually due to severe acute organic MR or sometimes a calcified AS. If the diastolic thrill, very common in mitral stenosis without mitral regurgitation and non-calcified stenotic mitral valve, especially in the moderate degree, produces a diastolic thrill. Presence of a diastolic thrill is a very significant aspect in mitral stenosis. In tricuspid area, again, I'm sorry for the mistake. The diastolic thrill is again a feature of tricuspid stenosis, and a severe TR can produce a systolic thrill. Aortic area, you can usually see a thrill which can radiate to carotids in presence of aortic stenosis. Then you can palpate the epigastric pulsations. You need to keep you can keep three fingertips, or sometimes you can also feel with the thumb kept in the sub-xiphoid process. So if this is your palpating finger, while keeping in the epigastric space, subxiphoid space, if the pulsation is felt at the fingertip, then it is usually due to RV enlargement. If the pulsation is felt at the pulp of the finger, then it is usually the aortic pulsations. This is how you are going to confirm whether the epigastric pulsations are due to right ventricular enlargement or the aortic enlargement. So, for summary aspect, I have summarized the precordial motion in some common cardiovascular diseases that are the exam cases. In what is the usual precordial findings in mitral stenosis? What can be seen? This depends again on the severity, presence of pulmonary artery hypertension, presence of coexistent regurgitation, and the presence of calcification. These are going to alter the precordial findings in mitral stenosis, whereas the apical impulse is usually normal or tapping in case of mild MS. In moderate to severe MS, it is usually displaced laterally in the same intercostal space, suggesting an RV enlargement secondary to pulmonary artery hypertension. And it can also be associated with parasternal heave. So these two aspects usually coexist. When you mention that apical impulse is situated laterally, but you don't mention parasternal heave, then there is some problem in your examination. Or the counterwise, you can see the parasternal heave, but apical impulse is normal. That is not a possibility. So you need to be very careful. In mitral stenosis, the apical impulse can be displaced laterally due to RV enlargement. Simultaneously, it can have the grade 2 to grade 3 parasternal heave depending on the severity of the coexistent pulmonary artery hypertension. Or if it is very mild MS, the parasternal heave can be normal and apical impulse can also be normal. And I was mentioning the diastolic thrill. It is very common. Try to palpate for diastolic thrill at the apex in left lateral position. If it is absent, for example, your final diagnosis is mitral stenosis and there is no diastolic thrill, then the examiner is definitely going to ask you what is the significance. If in a patient of mitral stenosis, moderate to severe degree, if there is no diastolic thrill, then either it has to be an extreme obstruction that is also called as critical obstruction, or it is very mild, or there is a coexistent calcified mitral valve. These can make the diastolic thrill obscure. And you can also see the palpable P2 in a patient of PH. Sometimes you can also feel the palpable P2 along with the systolic thrill in the pulmonary area in Newton-Backer syndrome, that is coexistent mitral stenosis with an atrial septal defect. You can have a systolic thrill at the pulmonary area due to AST or the pulmonary artery hypertension. In mitral regurgitation, similarly, in a mild mitral regurgitation, your apical impulse can be normal. But sometimes an aortic stenosis can be mistaken for a mitral regurgitation. It is very common that we are going to discuss why it happens. And apical impulse is usually down and out. And in an isolated mitral regurgitation, it is down and out and it should be hyperkinetic or hyperdynamic. And if it is there, then it gives a good prognosis of the repair. If you see a down and out LV apex, but it is heaving, that means it is sustained, then it is usually an aortic stenosis which you have mistaken for mitral regurgitation due to a presence of a systolic murmur. And you can also have a systolic thrill. If it has a coexistent mitral stenosis, you can have this diastolic thrill also. In again aortic stenosis, the typical apical impulse is heaving, in which it is forceful and sustained LV apex. Sometimes you can have a systolic thrill, which can be related to the carotid, which favors the organic aortic stenosis. If it radiates to the left lower sternal border, the thrill radiating to the left lower sternal border, it favors the subvalvular obstruction. and if it radiates to apex, it may mimic mitral regurgitation. So, to summarize, I have covered the important points of inspection and palpation with the main focus on apical impulse, how to identify the pathological apical impulse, which chamber is enlarged, etc. And the very most basic information that you can get about apical impulse is whether the heart is on the right side or left side. Never miss the dextrocardia. And your search is incomplete till you turn the patient to the left side to locate the apical impulse. And if it cannot be found, look for it on the right side. This simple measure can save you the humiliation of missing a case of dextrocardia. And when you make a diagnosis of an MS, go back to look for diastolic thrill at the apex. And if a student fails to detect it, and but the examiner finds it, especially the postgraduate examination, the implications are unspeakable. And my final MD examination case was a case of mitral stenosis with the coexistent aortic stenosis. Both are very severe in nature. I still remember that case. Uh, Patient, in fact, had a syncopal attack in front of me during the examination due to a severe aortic stenosis. So, this patient particularly had diastolic thrill. So, if you miss a diastolic thrill, the examiner can get very angry. Fortunately, I had so the remaining aspect we'll cover in the other classes.